grad program at UT Austin. And I've only worked in hospitals since then. I did my CF in Galveston on a little island, which is really exciting. We had like a jail as part of our hospital. It was very interesting. And the CF had to go to the jail, so that was my job. And then I went to a county hospital in Dallas. It's called Parkland Hospital. And then I met my husband and moved to California, and I've been working at UCLA for the last almost 5 years. So I am talking about swallowing physiology and the muscles related in dysphagia because I and a lot of speech pathologists, I think, feel this way. It's kind of confusing how to structure swallow therapy so that the patients can get the maximum benefit from the treatment that you're providing. So I started this research about a year ago with the director of our program, Andy Ehrman, to kind of understand more from the physical therapy, from the exercise physiology world, how we should direct therapy for patients so that they can get the maximum benefit. And really honestly, the research in this area for speech pathology is still ongoing. We do have some information from the speech pathology world, but there's still a lot that's being researched. I think there's actively lots of programs going on and lots of different studies happening all over the country to help us with answering this question: how do we structure therapy the best way for our patients? So the information I'm going to share with you today came from a really deep dive I took last year within the exercise physiology world. I spent a lot of time with some of our physical therapists at UCLA and a lot of time kind of like reading their textbooks and their research that they go through in their training and seeing how we can apply it for speech pathology.
I'm sorry to interrupt.
Yeah.
I just had a mic if you prefer, and if it's more comfortable for you, we probably could see if the cord is long enough to stretch to the desk so you could be
I'm
over
fine.
there.
Yeah, I'm fine. I think you might not be able to hear me.
Okay.
That's okay. Okay, any questions before we get started? So the first part of our presentation, I'm going to kind of take a deep dive into the physiology of oropharyngeal muscles, talk about how they're composed, how they differ from limb muscles, from skeletal limb muscles. And then I'm going to kind of go a little bit into theories of how muscles change with exercise. And then I will extend that into how we can use this information to direct swallow therapy. Okay, so first we're going to get a little bit granular and do a review of how muscles contract. I think this information is probably a review for most of you, but I want to make sure that we're all kind of starting off on the same page. So this information is going to be relevant in a few minutes when I start talking about muscle fibers and how they work. So muscles are composed of single large cells called muscle fibers. Each muscle fiber contains bundles of actin and myosin proteins, which are organized into into chains of repeating units like we see here. So let's talk about what happens to these cells during muscle contraction. So let's say you're going to take a drink of water. As you put the liquid in your mouth, sensory receptors detect the presence of the liquid and send information about the bolus to the brain. Then the brain sends the signal to the oral and pharyngeal muscles through a motor neuron. The motor neuron releases a chemical. This chemical binds to receptors outside of the individual muscle cells, starting a chemical reaction within the muscle. Then this leads the actin and the myosin proteins to slide past each other and shorten the muscle. That's called muscle contraction. And when the bolus is no longer present in the swallowing structures, the sensory receptors are no longer sending a signal to the brain and the muscle relaxes. That's kind of a basic overview of how muscles contract. And now I want to talk about muscle fibers. So this is probably also going to be a bit of a review for everyone, but I want you to kind of think about it from an exercise physiology point of view. I'm also reviewing this information because it's going to start becoming more important when we consider how the principles of exercise physiology apply to swallowing muscles. So we know that there's two types of muscle fibers, type 1 and type 2. Is it cut off a little at the end?
Just scooch the.
Yeah, here we go. Is that better? So type 2 muscles are broken down into type 2A and type 2B. The two types differ in how quickly they contract, how they fuel their energy, how big they are, and how much force they produce. So you're going to see this chart as I kind of go through talking about muscle fibers, and I want you to focus on the column that's highlighted as we go through the chart. We have slow twitch or slow contracting muscle fibers, which are called the type 1 fibers. And we have fast contracting muscle fibers, which are called type 2. All skeletal muscles in the body have a combination of both type 1 and type 2 muscles. And the ratio of type 1 to type 2 fibers in each muscle depends on the function or the action that that muscle needs to perform. The different types of muscles vary in how much force that they can produce. I want you to focus on the last column highlighted in blue. Type 1 muscle fibers contract slowly without a lot of force, but they're also fatigued slowly. So this type of fiber is found more frequently in muscles for posture and balance, which are actions we need to be able to perform for a long period of time without feeling as though we're exerting a lot of effort or getting fatigued easily. So for example, if you're standing in a really long line, you're using your back and calf muscles to keep you from falling over for the time that you need to stand in line. And these muscles predominantly have type 1 fibers. Type 2 fibers contract quickly with great force, but they also fatigue quickly. So this type of fiber is found in muscles that perform quick, forceful actions like flicking a bug away with your fingers or for eye blinking. If you blink your eye forcefully many times, you're going to feel like you're getting tired. Okay, so let's consider how these two types of fibers fuel their muscle activity. The fuel or the gas for muscle contraction is called adenosine triphosphate or ATP. Type 1 muscle fibers, the slow contracting type, and type 2 fibers, the fast contracting type, differ in how they make ATP. Let's look at the middle portion of the chart. So type 1 fibers are better at making ATP through an aerobic process using oxygen, which takes a little longer time to generate, but it can also fuel the muscle for a greater length of time. And type 2 fibers produce ATP through an anaerobic without oxygen process, which is produced more quickly, hence these muscle fibers contract more quickly. But the energy is depleted more quickly also. Type 2A fibers are highly adaptable. They have characteristics of both type 1 and 2B fibers. So sometimes they act more like a slow twitch muscle fiber, and other times they act more like a fast twitch muscle fiber, depending on the function that the muscle needs to perform. 2A fibers can produce energy through both aerobic with oxygen and anaerobic without oxygen processes. They can generate more force than type 1 fibers, but also last longer than type 1 fibers. And these fibers are used for sustained power activities such as a 400-meter sprint versus type 2B muscle fibers, which might be used for like a high-intensity, much shorter sprint. Okay, so let's talk about the size of skeletal muscle fibers. Fibers that are slower to contract and are slower to fatigue, the type 1 fibers, are smaller in diameter. Fibers that are faster to contract, the type 2 fibers, are larger in diameter. Okay. So now that we have a little basic understanding of how muscle fibers, the different types of muscle fibers, let's consider the muscles in the oral cavity, the pharynx, and the larynx with regards to their fiber types and what these muscles have to do. So we know that muscles have both type 1 and type 2 fibers, and the ones that are used for quick, forceful actions have more type 2 fibers, and the muscles used for actions that are low in force that we need to perform for a long period of time have type 1 fibers. So let's think about all of the activities of the oral cavity and the pharynx. This includes respiration, breathing, speech, masticating a bolus, and clearing it through the oral cavity and the pharynx. A lot of the muscles are involved in many or all of these activities. The demands of these activities requires highly different muscle activity, which ranges from maintaining tone for airway patency or rapid movements for speech, forceful bursts of activity for chewing and for swallowing. In contrast, the bicep muscle contraction just results in 2 actions: bringing the forearm close to the shoulder and turning the hand from a palms up to a palms down position. So it makes sense that the muscles in the oral cavity and the pharynx have a lot more unique combinations of type 1 and type 2 fibers than in any other part of the body to support the many different types of actions that they need to perform. So I'm going to now talk about some of the fiber type compositions of the oropharyngeal muscles individually. Understanding muscle fiber types can help speech pathologists organize therapy sessions and set goals. So if we know we're exercising a fast twitch muscle group that fatigues quickly, that patient's going to require a lot more rest breaks during exercise because they're going to get tired more quickly. There's some limitations to the information about muscle fiber types. First, there's very little information about the fiber type compositions for these particular muscles of the body. Some of the information I found was actually conflicting. And then all of the information that I'm going to present today was obtained from human muscle fibers, but the compositions of muscle fiber types for animals that are not humans are very different. And I'm not going to talk about that. So let's talk about the tongue first. Most of the articles I read state that the anterior part of the tongue is composed of a blend of the slow twitch and fast twitch muscle fibers. So this combination provides the structural support for rapid, repetitive, low force movements for speech, and it may explain why we don't get tired or fatigued with continuous speaking. And the posterior part of the tongue has a higher percentage of type 2B fibers. Remember, these are the ones that contract quickly and can generate great force, but they also fatigue quickly. So this allows for fast, forceful tongue-based contraction for swallowing, and it also allows for producing the g and the k sounds. The orbicularis oris, or the muscle responsible for pursing and retracting the lips, has a higher percentage of type 2 fibers. This allows for the forceful actions of lip pursing and retraction. You can actually feel the fatigue when you purse and retract your lips repeatedly versus no tongue fatigue with continuous talking. Okay. So now I want to look here at the digastric muscle. The digastric consists of 2 muscular bellies. Contraction of this muscle produces a range of movements from opening the jaw to hyoid elevation. The digastric is involved in speaking, chewing, swallowing, and breathing. Analysis of the digastric muscle in young males showed that it is composed of equal proportions of all 3 skeletal muscle fibers: type 1, type 2A, and type 2B in equal proportions. All 3 types of fibers were evenly distributed in a mosaic pattern in the muscle. So this muscle is likely composed of a mixture of all fiber types to allow for the many different actions that the 2 bellies of the digastric are involved in. Yeah.
Is it different for women?
I didn't find anything that was different for women or men. But I think what most of the researchers do is they take like several samples, some of them cadavers, some of them like not, and kind of just look at 10, 20 people and base it off of that. Yeah.
Is this going to be available for us?
I'll send it to Dr. Beal. Okay, so let's talk about the laryngeal adductors and abductors. The vocal fold adductors are primarily composed of type 2B fibers. These are the fibers that are fast contracting and fatigue quickly. This is likely due to the need for rapid vocal fold adduction to protect the larynx from aspiration. And the muscles responsible for abducting the vocal cords, the posterior cricoarytenoid, is composed of a mixture of fiber types, which allow the muscle to make precise adjustments for phonation and open quickly for respiration. Okay, let's talk about the levator villi palatini and the tensor villi palatini. These muscles are responsible for contracting the soft palate to close off the nasopharynx. These muscles are primarily composed of type 1 fibers so that they can close off the nasopharynx for a long period of time for swallowing and for speech. Let's look at the palatopharyngeus. This muscle attaches superiorly to the hard palate and inferiorly to the lateral wall of the pharynx. This muscle is involved in bringing down the soft palate and drawing the palatopharyngeal arches together so food and liquid doesn't enter the nasopharynx. It also helps to shorten the pharynx during swallowing. This muscle has the highest proportion of type 2 fibers than in any other human muscle in the body. These are the fibers that contract quickly, the type 2 fibers, and also fatigue quickly. Specifically, this muscle is composed of 2A fibers. These are the highly adaptable ones, and then less common another less common 2AB type. It's unclear why so much speed and force is needed for the soft palate. The inferior pharyngeal constrictor is a really good example of how muscle form follows function. This muscle has different functions for respiration, swallowing, and speech. This chart shows research on muscle fibers of the inferior pharyngeal constrictor. The research was completed at Mount Sinai Medical Center in New York. As you can see, type 2 muscles predominate the superior 1/3 of the inferior pharyngeal constrictor, and type 1 muscles predominate the inferior 1/3 of the IPC. The higher proportion of type 1, the slow contracting, slow fatiguing fibers in the lower part of the muscle likely helps with tonic contraction at rest. And the higher proportion of type 2 fibers in the superior part of the muscle probably helps with the forceful movements needed to clear the bolus through the pharynx. Okay. All right. Now I want to spend a few minutes talking about some muscles that have unique fibers that are not found in skeletal limb muscles. I have to get granular again for a moment. So in the first slide, we talked about how there are proteins called actin and myosin involved in muscle contraction. And another way to think about the process is that ATP is the fuel that powers the movement, and then actin is like the train tracks, and myosin is the motor that moves the muscle along. I want to talk about the myosin protein for a moment. Myosin is made of myosin heavy chains and myosin light chains. These two chains wrap around each other to form the myosin protein filament. The myosin heavy chains are the part of the motor that actually break down the ATP to fuel muscle contraction. So the faster the myosin heavy chains break down ATP, the faster the muscle contracts. There are many different types of myosin heavy chains, and the different types are referred to as isoforms. So faster myosin heavy chain isoforms are found in the faster contracting type 2 muscle fibers, and the slower myosin heavy chain isoforms are found in the slower type 1 fibers. Most muscle fibers, especially in the limb muscles, have purely one type of myosin heavy chain in the muscle fibers. Other muscle fibers have a mixture of different types of myosin heavy chain forms and are therefore known as hybrid fibers. There are more muscles with these hybrid fiber types in the oral cavity and in the pharynx than in the limbs. This is likely due to the need for oropharyngeal muscles to perform a variety of functions, because remember, form follows function. Was that clear? Yeah. Okay. So the cricopharyngeus is a great example of a muscle that has these hybrid fiber types due to a mixture of myosin heavy chain forms. Researchers have found that the cricopharyngeus is composed of 2 layers of fibers. The inner layer is composed primarily of slow contracting and slow fatiguing type 1 fibers. The outer layer is composed primarily of faster contracting type 2A fibers. The inner layer is noted to have higher levels of oxidative enzymes, which means that it uses oxygen to generate its energy, which may suggest that the inner layer has a greater role in maintenance of the resting tone of the UES. And the outer layer may have more of a role in swallowing. So let's talk about the muscle fibers that make up the CP. Remember, those myosin heavy chain isoforms that are important for how quickly the muscle contracts. Unique myosin heavy chain isoforms that are not seen in the human skeletal muscles have been found when looking at the cricopharyngeus and cadavers. This includes an isoform that's more commonly found in birds, an isoform that's generally seen in the heart, and 2 other isoforms that are seen in neonatal developing muscle fibers and generally are substituted by adult fibers in the limb muscles as we get older. Researchers believe that the unique hybrid fibers allow the CP, the cricopharyngeus, to contract at varying speeds and force, likely depending on the bolus size and the volume. Yeah, this is a perfect time.
For the neonates, can you kind of repeat what you were saying about
Yeah,
how that changes?
So basically, there are some types of fibers in infants that are replaced by adult fibers as we get older. But in the CP, they found one isoform, one type, or maybe more than one, that was only seen in infants. We don't see it anywhere else, or in newborns. Yeah, we don't see it anywhere else. So that was interesting. And then that there's some that are only found in birds. So it just shows how unique these muscles are. Yeah.
And they're just kind of like replaced, or
generally, like in the limbs. Yeah, those muscles just sort of change into kind of an isoform, like that myosin chain, and it's something that's more typical for adults. The functions change for what those limbs have to do from when you're an infant to when you're older, and the myosin chains change as well. But the type that was found in the CP was something that's only ever seen in. Good question. Okay. So there are more muscles with unique muscle fiber types. There is evidence that suggests that the fast type myosin heavy chain isoforms are actually found in the laryngeal adductors, which makes sense because the larynx has to quickly adduct to close and protect the larynx from aspiration. And mixed fast and slow myosin heavy chain isoforms are found in the PCA, the laryngeal abductor, which makes sense because this is involved in pitch variation. I want to give you one more example of a muscle with hybrid fiber types. This is the masseter muscle. This muscle is involved in elevation of the jaw and moving the mandible forward for protrusion. Researchers have found unique muscle fiber combinations in this muscle and some myosin heavy chain isoforms that are not found at all in skeletal limb muscles. So these unique myosin, the isoforms combine with the typical type 1 and type 2 fibers to allow the masseter to perform these kind of very different actions. Okay. So before we sort of move on to exercise physiology and the principles, does anyone have any questions about what I just talked about in muscle physiology? Okay, moving on. So let's just review the ways that the oral, pharyngeal, and laryngeal muscles are different from skeletal limb muscles. There's three primary ways. First, the oral, pharyngeal, and laryngeal muscles are involved in a lot more functions than the skeletal limb muscles. For example, the tongue is involved in speaking, forming a bolus, and transporting the bolus through the oral cavity, and we talked about how limb muscles like the bicep are really only involved in two things, bringing the forearm towards the shoulder, moving the arm from palms up to palms down position. There's a lot more unique combinations of type 1 and type 2 fibers in the oral cavity and in the pharynx than are found in skeletal limb muscles. And finally, there are also hybrid fibers that are found in these type 1 and type 2 fibers in the oral cavity and pharynx that are not found in other parts of the body. These hybrid fibers impact the speed at which the muscle contracts. Thus, they possibly impact the endurance and fatigability of the head and neck muscles. Since muscle form follows function, it makes sense that the muscles in the head and the neck have a lot more unique properties than skeletal limb muscles to support the wide range of actions that they need to perform. All right, so it's a little review. So there are some well-established theories that discuss how muscle and neural change with exercise. Initial benefits from an exercise are usually due to changes in the way that the nervous system activates the muscle. Early changes in neural activation improve muscle coordination and precision of movement, and this falls into the theories of neuroplasticity or motor learning. Learning how to type is a very good example of neuroplasticity. When we're beginning to learn how to type, we have trouble finding the keys. We have to look down at the keys. We're slow, making lots of errors. As we continue to practice, we can find the keys more easily. We don't have to look down as much. We're faster. Essentially, our brains have rewired. Neuroplasticity has occurred. Anyone want to give another example of an activity that's kind of like that, where we start off difficult? Go ahead. Mm-hmm.
It'd be like tying your shoe.
Yeah. Usually it's kind of takes children a little while to kind of like figure out which laces and how to put things together. That's a good example. Any others? Yeah. Riding a bike is an excellent example. Yeah. Anyone else? Good examples. Okay. With continued exercise, the muscle becomes larger. This is called hypertrophy, and it's the primary goal of resistance training. The exercise science literature has established that hypertrophy can begin to occur as early as 5 weeks into a resistance training program, but only if the program is sufficiently intense in terms of the effort exerted at each repetition, the number of repetitions completed, and how often the individual exercises. It's also believed that with continued training, the fast contracting and fast fatiguing muscle type 2B fibers can eventually transition to a slower fatiguing 2A fiber that has more endurance and may have the same or less force. But this is a new area of research with muscle physiology, and it's not definitive. But there is some research that suggests that muscle fiber types can change. So, speech pathologists generally know which exercises would benefit a patient with different various swallowing deficits. For example, someone who has reduced pharyngeal contraction, we might want to do an effortful swallow. Any other exercise you can think of that might help with someone who has reduced pharyngeal contraction? That's more of a maneuver, not really an exercise. That's kind of like an adaptation or something we can teach a patient to do to protect their airway. Anyone for if a patient has reduced laryngeal elevation, what exercise might we? Exactly, the medicine. Very good. Yeah, yeah. So we know what exercises to ask a patient to do when we see that their swallow on a modified or a fees, and we can see what's contributing to their dysphagia, what the problem is. We know what exercise to prescribe. But there's little information in the dysphagia rehab literature on how to structure therapy in terms of how much effort to ask the patient to exert with each repetition of an exercise, how many repetitions to perform in a session, and how frequently patients should exercise. It's okay.
How do you also measure their effort?
That's a great question. We're going to talk about tools that you can use to measure effort. We have some good ones now. So the American College of Sports Medicine has compiled current research on resistance training and skeletal limb muscles. I'm going to be drawing on their guidelines as I discuss some of these principles of exercise physiology. And then once we kind of get through the principles, I'll talk about how we can do this for swallowing therapy and actually the tools that we can use to measure how much effort a patient's exerting. Resistance training is also known as strength training or weight training. That's any exercise that requires muscle contraction with effort to counter a force. So basically, resistance training or weight training, strength training is any type of exercise that requires the muscle to contract against some sort of force. So we can think of this as the amount of strength needed for bolus clearance, clearing a bolus through the pharynx and through the oropharyngeal structures. We can talk about this as the range of motion needed for hyolaryngeal elevation. But I want to note here that simply just swallowing without increased effort is not considered resistance or strength training. The exercise science literature has established that hypertrophy will begin to occur as early as 5 weeks into a resistance training program, only if the program is sufficiently intense in terms of the effort exerted at each repetition, the number of repetitions per set, the number of sets per session, and the number of sessions per week. So if a patient asks, how long will it take for me to get better? It could happen in 5 weeks if all of these things are done well. Okay, so this is the classic model for a healthy, cognitively intact individual such as yourselves looking to improve strength or power. This model can be difficult to implement with patients because they have a lot of medical complications. They're likely starting off with more restricted functional reserve than healthy individuals. And some of our patients may not be cognitively intact, which can impact their ability to participate in a strict program like this. Finally, I want to note that this program doesn't apply to concerns about endurance or coordination. This is a strength training program. So the first step for a classic strength training program model is to establish the maximum intensity with which the individual can do the exercise. Then you begin exercising at a percentage of the maximum intensity. Then you reestablish the maximum when the individual can do the exercise at regular intervals, and then vary the amount of effort per repetition, the number of repetitions of the exercise, the number of days a week you exercise systematically during the program for muscle change to continue to occur. So I'm going to give you the formula that's described by the American College of Sports Medicine, and then we can talk about how to do this for swallowing therapy. So let's talk about step 1. This is establishing the maximum intensity. So when talking about the load placed on the muscle, the exercise science literature uses the term repetition maximum. 1 repetition maximum is the maximum load a person can bear to complete a single repetition of an exercise. So when we think about someone beginning to lift weights, this is the maximum weight that the individual can lift one time. For physical therapists, 1 RM is usually only calculated when someone's training for like a competition. And rehab therapists find that 1 RM is really challenging to calculate in therapy, and they generally use alternative methods. At UCLA, we use technology such as SCMG and IOP, which I'm going to talk about in depth in a few minutes, to calculate and establish the patient's 1 repetition maximum. Without instrumentation, our ability to measure swallowing performance, or like the effort for swallowing exercise, is very limited. Physical therapists often establish the baseline maximum by asking a patient to perform as many repetitions of an exercise as they can, and when the patient starts to show fatigue with the task, they're at their repetition maximum. So by fatigue, I mean reduced coordination, so such as dragging feet with a walking task or not putting one step exactly in front of the other. Fatigue can also be slowing down with each repetition or pausing between repetitions. And it can also be a patient's report that they are fatigued. The challenge with these methods is that they're all subjective. Another method is to have the patient perform the activity a few times and take the highest intensity or the maximum intensity as your 1 RM. So this is the method that's used with the Iowa Oral Performance Instrument, or the IOP. Does anyone know about this device? I'm going to talk about it in just a few moments. Basically, it's a device where patients are asked to press a bulb that's put in their mouth against the roof of their hard palate three times. And the hardest of the 3 is taken as their maximum intensity. So it's an exercise tool that is pretty recent in development. It's used pretty much, I think, in most dysphagia therapy programs across the country. Basically, it's like a little computer type of device, and it's connected to a bulb, and you put the bulb in your mouth in different locations, and the patient is to squeeze the bulb with their tongue. And it's used for tongue strengthening. And the way they take the 1 RM is they ask the patient to do it 3 times, and you take the maximum of the 3. And then you would do it in different locations of the mouth. I'll show you a picture of it in just a moment. I want to talk about an alternative that can be used when instruments are not available to measure performance. Another alternative to establishing 1 RM is to ask a patient their own rating of perceived effort. So these ratings of perceived exertion have been shown to provide a good estimate of heart rate and can help the clinician understand how hard the patient's working. The Borg scale is a very well-established scale. It ranges from 6 to 20, so 6 is no effort at all, and 20 is exerting the maximum effort you possibly can. And then you multiply your rating times 10 to get the current heart rate. So physical therapists will often use a basic 0 to 10 version of this scale at the beginning of therapy, before they start therapy with a patient, and then throughout, to understand how hard the patient's working. And you want the patient to be working at about 5 to 6 out of 10 when it's adapted. And I'll show you an adapted scale in just a moment. So these types of perceived effort scales are subjective, and they work best when the patient's cognitively intact. The exercise science literature tells us that the therapy program should be structured based on the end outcome. So let's talk about the objectives of dysphagia therapy first, then we can talk about the variables that you have to manipulate to achieve these objectives. Are we about halfway through? Getting close?
9:30.
Okay. So about 15 minutes, we'll take a break? Yeah. Yeah. Okay, so coordination with regards to oral preparation refers to the movements that are precise in the timed events for swallowing can occur when they need to. So someone with poor swallow coordination may demonstrate imprecise oral tongue movements for bolus transit, which can result in material entering the pharynx prematurely. A delayed response for triggering the swallow can also indicate problems with coordination. We generally don't consider endurance during dysphagia assessment since FEES and modified barium swallow studies look only at a few trials of PO, but endurance may play a greater role in this group of muscles with their very unique fiber types. The research on endurance related to swallowing is still new, but there is some evidence to support that eating a meal does reduce tongue strength and endurance. So researchers at the William S. Middleton Memorial VA Hospital found that a group of younger adults and older adults had reduced tongue strength and endurance measured with that IOP device I was just talking about after eating half a bagel with peanut butter and carrot sticks and drinking 8 ounces of milk. These researchers didn't find any relationship between the patients reporting a sense of fatigue, but the IOP measurements suggested that their swallow muscles were possibly fatigued, even though they didn't feel like it. Yeah, it's okay.
Do your muscle fibers change as you get older? Do different position?
You know, I don't know. I haven't looked into that, but that's a really interesting thought. Certainly the way you use your muscles will probably change as you get older, so that could impact things. I think it might be hard to delineate whether it's age that's impacting it or other factors, but it's definitely something worth looking into. Yeah. Going back to endurance, some patient populations we should be thinking about with endurance are patients who report a abnormally long meal time, patients with unexpected weight loss, patients who are not eating all the food on their tray, which at UCLA a dietitian told me would be anything less than eating one entree and at least one side. So if they're not completing a full entree and a side pretty consistently, then that might be someone to think about having endurance issues. And any patients with unexplained, unexpected weight loss. Okay, let's talk about power. When we are referring to power, we are referring to the overall strength of the patient's oropharyngeal structures to clear a bolus and protect the airway. We cannot measure strength on modified barium swallow studies or FEES. We can only infer about a patient's strength based on their range of motion for airway protection and from the residue that's remaining after they swallow something. To accurately understand strength, we would need to do manometry, which is a very new type of science that's being used. Basically, does anyone know what manometry is? It's really interesting. Basically, the GI physicians do this a lot. They have like a long probe with different sensors that they can put into the structures and watch the strength that's being exerted on those sensors as someone's swallowing something, and that can tell them about strength. So really the only way we can know about the actual strength that the muscles are exerting is with manometry. And with modified barium swallow studies, we basically infer strength when we see a lot of residue in an area. We think that that area might have decreased strength. Or if we see that the patient isn't protecting their airway, then they probably don't have the strength to elevate the larynx and bring it out anterior and superior. That could be a reason why too. So we just sort of have to make inferences based on what we see. Okay, so let's quickly talk about the variables we can manipulate for muscle change to occur. The human body adapts pretty quickly to a single exercise. So think about the last time you did a new exercise. You probably thought that the exercise was very difficult at first, but then after doing the same exercise for some time, it started to feel as though you could coordinate the steps for the exercise more easily. So that likely meant that neuromotor programming or neuroplasticity had occurred. Then, when you're able to do the exercise without fatiguing as quickly as when you first started, it's likely that hypertrophy occurred. Since the body adapts so well, the exercise science literature tells us that we have to make modifications to the exercise for muscle change to continue to occur. These modifications include increasing the effort with which we're doing the exercise, the number of repetitions with which we're doing the exercise, how often we're exercising, the length of rest breaks between sets of exercise, and all of these things have to be manipulated systematically for muscle recruitment. So therapists have to manipulate these variables differently for each patient depending on whether the goal of the therapy is to improve coordination, improve endurance, or to improve power. I think, why don't we take a little break here, and then we can kind of talk about each of these variables differently, and then I have one patient example and some other tools that we can talk about afterwards. Okay.
Are the presenter notes also going to be?
I have sent Dr. Beal my notes.
I would love that.
Yeah, I've sent them to Dr. Beal. Should we pause the recording for a moment? So we're going to take a break.
You
I'll
know,
let you do it.
if we pause it, it will start a new one. If I stop it, it'll be a new recording, but let's see if there's a pause. There it is.
Want to get some sunshine?
So this has, pause. There's a pause. Great.
Perfect. So are we? Yes. Are we recording?
Let me just make sure the red film's, yep, it is recording if that's red.
Yeah.
Great.
Okay, good. And then just down here.
Get back to yours. I know his toolbar like minimizes.
There we go. Thank you. Okay, so before the break, we were talking about how there's different variables that we need to manipulate for muscle change to occur. Oh, thank you. And the kind of 4 categories that these fall into are volume, intensity or the effort of the exercise, frequency, and rest period. So let's talk about how we can manipulate these. The human body adapts pretty quickly to an exercise. So the last time you did an exercise, you probably felt like it was really hard to do at first, and then after you started doing it for a few minutes, it felt like you could coordinate the steps better, so neuromotor programming or neuroplasticity occurred. And then when you started doing the exercise more frequently, your muscles got stronger, you didn't get tired as frequently doing the exercise, so that probably meant that hypertrophy occurred. We have to change these variables systematically during therapy for each patient, depending on whether the goal is to improve coordination, endurance, or power. So I'm going to talk about these individual variables and how we can kind of think about how they need to be adapted for each patient. So from a physical therapy standpoint, if the goal is to improve endurance or if the exercise is new, then we should do more repetitions with less effort initially. The American College of Sports Medicine recommends about 8 to 12 repetitions. If you're proficient with the exercise and you want to gain power, then less repetitions, such as 6 to 8 reps per set with more effort is best. The goal with strength training is to exercise until the patient feels fatigued or starts to show poor technique. Studies suggesting the ideal volume and intensity for oropharyngeal muscles don't exist, and we're drawing this information based off of exercise physiology.
Can you say that last sentence? The last sentence one more time?
So we don't have any research for how to structure volume and intensity for oropharyngeal muscles. We are drawing these principles based off of exercise physiology principles. Yeah. Let's talk about intensity for a moment. Exercise scientists talk about intensity in terms of resistance loading or the load placed on the muscle. So for weightlifting, a 10-pound weight is not a lot different from a 20-pound weight. For weightlifting, a 10-pound weight is not a lot different from a 20-pound weight, but let's talk about swallowing. There's more load placed on the swallowing muscles when you're swallowing a bagel with peanut butter versus just swallowing a sip of water. With the sip of water, you're only really using a small amount of the maximum force that the muscles can generate. From an exercise point of view, to increase muscle strength and the functional reserve, we must increase the load beyond what is generally used for swallowing for a sip of water or a bite of food. So to make the muscle stronger, you have to make the muscle work harder than it generally does. This is the principle of resistance loading. As the swallowing muscles adapt to the exercise, the load placed on the muscles must be progressively increased in order to increase muscle strength. If a person is just swallowing repetitively with normal effort, we can't expect the muscle to get stronger. So increasing the load can mean increasing the effort for each repetition or the number of repetitions at a certain level of effort. Let's talk about the ideal scenario for applying resistance loading, and then we can talk about how to do this for therapy. So this is the model we would use for a healthy individual looking to improve their strength. First, you establish the 1 RM or the repetition maximum. That's the maximum load that the person can bear in one repetition of the exercise. The American College of Sports Medicine states that an untrained or somewhat trained weightlifter should begin lifting weights at 60 to 70% of their 1 RM. Okay, so if our weightlifter can load 100 pounds, then 60 to 70% of their 1 RM would be 60 to 70 pounds. But an experienced weightlifter, someone who's been lifting weights for a long period of time, they would begin at 80 to 100% of their repetition maximum. So they might begin at 80 pounds if their maximum was 100 pounds. At the start of their exercise program, a new weightlifter would establish their 1 RM by lifting the maximum weight that they can in one repetition, so that could be 100 pounds. And let's say our untrained weightlifter is lifting 60 pounds on each repetition for a set of 10. We're trying to make this simple. When he can lift 60 pounds for more than 10 reps during 2 exercise sessions, it's time to increase the weight by 2 to 10%. So let's increase the weight by 8%, which is 5 pounds, and that's the next heavy weight when it comes to weightlifting. So now he starts to lift 65 pounds per rep for a set of 10. And when he can lift 65 pounds for more than 10 repetitions across 2 sessions, it's time to increase the weight again or consider changing the exercise depending on what his goal is. This continuous increase in load is necessary to continue to increase strength in the muscles. Let's talk about how to increase resistance for improving power in swallow therapy. So first you would establish the maximum intensity. Then you would set the target at a percentage of that maximum intensity and increase the target when they achieve it. So increasing the target could mean increasing the percentage of the maximum intensity that's set for the session. So let's say you started at 60%, you want to increase to 65 or 70%. That means increasing the target. Increasing the target can also mean increasing the number of sets completed in a session. And it can also mean increasing the frequency with which the individual exercises, for example, from 2 to 3 days a week to 4 to 5 days a week. And then finally, you can also decrease rest breaks between sets of exercises to increase intensity. Let's consider how many days a week individuals should exercise for maximum benefit. According to the American College of Sports Medicine, a healthy individual who's new to exercise should train the entire body 2 to 3 days a week. When the individual is stronger, they should train 3 to 4 days a week. In the physical therapy world, if you're working on endurance and you're not fatiguing the muscles at each session, then you might want to start exercising at 4 to 6 days a week. But if you're working to a level of significant fatigue, then you should alternate days of exercise with days of rest. The optimal frequency with which we should exercise the swallowing structures is unclear. But research programs with good designs, such as that IOP device, have reported progress when the patient exercised about 3 days a week. According to the physical therapy model, patients need about 1 to 2 minutes of rest between sets if the exercise is less demanding, such as lifting a 5 to 10 pound weight, and about 3 to 5 minutes between sets is needed for heavy or high load exercises, such as with like squats. Rest periods should be extended if the patient's performance starts to get sloppy or fall below the target load, and I'll usually see my patients will start to like hunch forward, or they'll like relax back more, or I'll see them kind of try to get started with the medicine, but they can't get the larynx elevated. So once those kinds of things start happening, I will ask them to take a rest break. And maybe we need to reconsider how many repetitions they're doing per set. Rest periods should also be extended if the patient reports more than moderate level of fatigue. So if they're saying, I'm getting really tired, then you should give them a rest break. And in just a moment, I'm going to talk about some fatigue measurements. So I want to introduce a patient to you who's going to kind of help us talk about the rest of these theories. This is patient X. He was a patient of mine that generously allowed me to use his case as an example. He is 62 years old. He has a history of right oral tongue cancer. This is sort of a shortened version of his history, but he had a right hemiglossectomy, which means that so a part of his tongue was removed, the tumorous part, and a forearm free flap for replacement. And he also had a right pharyngectomy, so partial on the right of his pharynx. He also had a right neck dissection. All of this happened in December of 2016. And then he had chemotherapy and radiation treatment in April of 2017. So the first time we saw him was in September of 2018. He had a complaint of feeling like he needed to cough after all sips of water and difficulty clearing food from his mouth and throat. He was completely G-tube dependent for 1.5 years when I saw him.
Question.
Yeah. Good.
Forearm free flap?
Yeah, that's a good question. So this is your forearm. So the surgeon will take a flap to replace the muscle that's been taken. Yeah.
Do those fibers gel?
There's
start working?
there's no innervation. There's no innervation. It's
I
just
mean,
bulk.
So it's just bulk. It's not.
Yeah. Mm-hmm. Yeah. Okay, so I'm going to play a short clip of his modified barium swallow study. Have you guys, has everyone sort of been exposed to modified barium swallow studies a little bit? Okay, feel free to ask some questions if something doesn't make sense. I'll do my best to explain it also. So you'll see when you're seeing his swallowing that he has poor oral control. He aspirates thin liquid due to premature spillage and reduced laryngeal elevation, and from pharyngeal residue after the swallow. Orally, you'll see that he requires more than 40 seconds to chew solid food. He has difficulty moving food from his mouth to his pharynx because a portion of his tongue was removed. His pharyngeal contraction is reduced, which results in a great deal of pharyngeal residue with all textures. The residue increases with viscosity. We tried some head positions during the study. They're not in this video, but the head positions were not any beneficial for reducing aspiration. So things like turning his head from right to left while he's swallowing. You will see during the study that he turns his head while he's chewing, and I asked him to do that so that we can see his chewing in an AP type of view, which allows us to have a little more information about what he's doing with his tongue. Okay, so I'm going to play it now. Oh, maybe we should turn the lights down more. This is pretty bright. It's going to be hard to see. Let's just go back to the beginning. Is that the most? There's definitely. Wait. Thank you. Oh, perfect. Is that better?
Yes.
Yeah? Okay, cool. Great. Okay. So this is thin liquid. So this is him chewing, and he's looking at us so we can kind of see that he's chewing more on the stronger side. He's having trouble clearing the bolus. Okay, want to see it again? Or kind of clear? One more time?
What was the texture of the bolus?
The first one's just water, thin
And then
liquid.
was chewing.
I think a cookie. Yeah, Lorna Doone. It's pretty effortful to get that down. Okay.
I have a basic question.
Yeah.
When the water goes down, does he feel that?
That's a good question. So this patient did not consistently cough when he aspirates.
Okay, so it's-
He had radiation, and radiation generally reduces sensation for aspiration. So it's not unexpected. Okay, so based on these findings, I decided to work with him on strength training to improve bolus clearance. And specifically, I decided to do a three-level approach to treating him. So one, we were going to work on the effortful swallow to improve pharyngeal contraction and bolus driving force. And then we were going to work on the Mendelssohn maneuver to improve the laryngeal elevation. And then I was going to work with him on the IOP, the Iowa Oral Performance Instrument, to improve the strength in the native part of the tongue, so not the area that was surgically operated on, the remaining. And then I also did train him on the supraglottic maneuver for airway protection with the thin liquid, which I won't go very much in depth with that because he was able to learn it pretty quickly. So now that you've met my patient, I'm going to talk about how we can sort of apply the exercise physiology formula to shape his treatment plan. Okay, so I want to talk about kind of the main tool that we use to establish repetition maximum and effort in swallowing therapy. At UCLA, we have two tools, the SCMG, which is it's called surface electromyography, and the Iowa Oral Performance Instrument, which I'll show you guys in just a moment. So SCMG uses submental electrodes to look at the activity of the suprahyoid muscle group during swallowing. The relative strength and timing of contraction of this muscle group is displayed on a computer screen, and we can use the line, let's see, is it? Yeah. Okay, so we can use the line right here to set the target, and you can just move this line up and down on the computer. And then you can see how the signal changes, the color changes as it crosses the line. So this is my colleague Christy Hall demonstrating use of the SEMG, and then here's the activity on the computer screen. The SEMG picks up the electrical charge that's generated when the motor units fire. And more effort means more motor units are recruited. So the screen is displaying the electrical release that occurs when the motor units fire. Does that make sense? Okay. The horizontal axis shows how long the motor activity is occurring. So this is time down here. And the vertical axis shows how much electricity the SEMG is picking up from the muscle cells. So this is what we would interpret as effort on the vertical axis. So the harder someone works, the higher up the signal goes. The first peak here is a normal swallow. Right here. The first peak down here is a normal swallow, and it's about 1 second. And then here you'll see an effortful swallow. And then as we keep going, you'll see Christy performing the Mendelssohn maneuver, and she's holding it for 5 seconds. Okay, so SEMG allows us to establish the maximum intensity with specific dysphagia exercises, such as the effortful swallow, the Mendelssohn, the Shakir, the chin tuck against resistance. Have you heard of that exercise? Yeah? Yeah? Okay, good. And to monitor the effort that the patient is exerting to do each exercise, to change the target effort or the load that the patient gets as the patient gets stronger, and then also provide biofeedback to the patient because they can see what they're doing on the screen. Now, I want to talk a little bit more about the SEMG. There's some challenges that result in uncontrolled variability and measurement with the SEMG. So we can't calibrate or zero out the device like you could with a scale. So with a scale, when you get on the scale, you're the same weight, that day when you get on. With the SEMG, if the electrodes are placed submentally and there could be a small degree of variability in where they're placed from session to session, we try to keep it as close as we can, but there is a little bit of variability. Also, the electrodes directly measure anterior suprahyoid and floor of mouth muscles because you're placing the electrodes here, or the lateral strap muscles, but we're unable to measure pharyngeal contraction with the SEMG. We can't access the energy of the posterior pharyngeal wall, but there is an idea that I've read in several articles about the SEMG that swallowing is synergistic, and we can expect that a higher level of activity in the suprahyoid muscles also means that there's higher level of activity in the other swallowing muscles and the pharyngeal contraction also. Let's see. So I just wanted to kind of show you some other fields that use SEMG. So we are not the only profession that uses electromyography for even for therapy or for other types of things. So it's kind of interesting. So just a few notes about where the SEMG is placed. So you want to wipe the skin with an alcohol wipe and make sure that there's no lotions or oils on the skin because this can impact the reading. You cannot use the SEMG with patients who have facial hair. The patient has to shave, and I've had patients say no, they don't want to do that. Patients undergoing radiation often have redness and irritation in that area where their electrodes would be placed, and they may not be comfortable with the SEMG, so we don't use it with them. And then patients also who've had radiation a long time ago, that tissue is fibrotic, and sometimes the readings aren't very good. And then sometimes I've had to add medical tape, like borrowed from nursing, to keep the electrodes in place because it just doesn't stick well for certain people. Okay, so I want to talk about some other types of ways to talk about effort and look at patients' effort for therapy, in addition to biofeedback or the SEMG. The patient's personal rating of fatigue can also help us understand their performance and help us understand why it's deteriorating. So if you don't have biofeedback tools, which not all clinics do, you can use the patient's fatigue rating to establish the baseline and monitor progress. So physical therapists actually use fatigue to establish the baseline maximum also, by asking a patient to perform as many repetitions as they can of an exercise, and when they show fatigue, then they're at their maximum. So that's, if they're having some reduced coordination, or if they're showing like less precise movements with the activity, then they're showing that they're at their baseline maximum. We've already discussed the Borg scale, but in the next slide, which was the 6 to 20 scale that correlates to heart rate, the next slide I want to talk about a 1 to 10 scale that we use at UCLA. So the Borg scale is 6 to 20, correlates to heart rate, and if you want to read more about it, there's a citation at the end. Physical therapists use a modified version of the Borg scale when they're doing therapy, and that's a 1 to 10 scale. So they use this 1 to 10 scale because it's easier for patients to understand it, to assess their fatigue, and we've adapted that 1 to 10 scale for swallowing, and this is kind of what our fatigue scale at UCLA looks like. Yeah, we had someone in our office draw that for us. So this is a picture of the 1 to 10 scale. I would introduce this to the patient by explaining that this is a scale to quantify how fatigued or tired the patient feels as he's doing swallowing exercises. Then I explain what each number means. For example, I would give myself a 1 to 3 if I'm just taking like a leisurely walk, and I would give myself a 7 to 9 if I'm running or taking like a hot yoga class. And I might give myself a 10 at the end of a marathon. Then I ask the patient to select the number that best reflects how they are feeling before they start therapy. This is really important because in the hospital, I'll find that many patients will select 3, 4, or even 5 just while they look like they're resting in bed, especially because if they're having breathing difficulties, or if they just finished something like dialysis that's really exhausting, or even if they just had physical or occupational therapy, or maybe they just had to get up to go to the commode and come back into bed, and even if that was just 20 or 30 minutes ago for a patient in the hospital who's pretty deconditioned, that can be pretty effortful. So we want to know where they're starting from before doing therapy, because we don't really know what was happening in the 30 minutes before we came into their room. An outpatient, I have a lot more patients who just say, oh, I'm at a 1 or I'm at a 2. Yeah. So I ask the patient, I put this in front of the patient and ask them to select how they feel frequently during therapy. And the reason I want to do that is because I want to monitor how they're feeling, whether or not we're using the SEMG, but also a lot of these exercises we're asking them to do on their own outside of therapy. So maybe I'm seeing them once a week, but they're exercising 2 to 3 days a week. And I want them to be able to monitor their own fatigue at home, because yes, you can buy a portable SEMG machine, but it's kind of expensive. And so this is what our patients are using at home to monitor how hard they're working. So there's no research suggesting where we want a patient to be during dysphagia therapy on this scale. Like, we don't know if we want them to be working between what numbers to have the maximum benefit. But the physical therapists at UCLA like the patients to be working at about 5 to 6 on the 10-point scale, which is moderate fatigue, or 130 to 140 heart rate on that Borg scale. If a patient selects extreme fatigue, I usually ask them to take a break before continuing on to the next exercise, or we just stop for that day if the session's over. Yeah. Any questions about the fatigue scale? Okay. Let's go back to patient X. So I want to show, here we are using the SCMG to obtain X's baseline maximum with the effortful swallow during therapy. I'd like for you to look at the syringe at the bottom of the screen. In order to ensure that all repetitions of an exercise are similar, I want the patient to swallow the same texture and the same volume for each repetition of the exercise. We want to be sure that we're comparing apples to apples when the patient's exercising. So this patient X took 1 cc of nectar thick liquid for each repetition of the effortful swallow. And this is what he did in the office, and at home I sent him home with syringes. So this amount was selected because it yields the least aspiration risk for him, but also gives enough lubrication for him to do the exercise. At the top of the screen, you'll see the SCMG results of 3 effortful swallows. Of the 3 swallows, his maximum intensity was the highest at 140 microvolts on the second swallow. So we took the 140 as his maximum, and we're using 60% of that for the target or the goal during that session. So 60% of the maximum, the 140, would be 82 microvolts. And that's the line that's set as the goal or the target for a full swallow for him for that session. That make sense? Yeah? Okay. I don't know why it's doing that. Okay. This chart shows patient X's performance over 4 therapy sessions. As his performance improved, I increased resistance by asking him to perform more sets per therapy session. We kept the number of repetitions per set constant, and we kept the level of effort based on the percentage of his maximum performance constant. So during sessions 6 and 7, he met his SCMG target 100% of the time for 6 sets, and he reported his fatigue to be 6 out of 10, which means he was working at about moderate intensity. During sessions 8 and 9, he reported 4 out of 10 fatigue when he got to set 6, and then he requested to keep doing the exercise. So we increased the load and stopped exercising at set 8 when he said that he was now 6 out of 10 fatigue. Increasing the load from 6 sets to 8 sets was a pretty big jump. It was more than that 2 to 10% that's recommended by the American College of Sports Medicine. But I want to note that his accuracy remained high. He wasn't sloppy. He was performing the exercise with good technique. There weren't any maladaptive behaviors, like he wasn't hunching or he wasn't, straining his neck or something. And his fatigue didn't increase, and he didn't report any pain. So that's why we increased by more than that 2 to 10%, which I've noticed a lot of our patients are able to do that in swallow therapy. Okay, so this is the clip of him doing the effortful swallow and us using the SCMG. You can see it on the screen. There's a thin horizontal line for the goal. I think you can probably see it. It's like right there. That's the goal that he wants to hit. It was set at 60% of his maximum intensity for that session. And the signal changes color when he goes up on the line, crosses the line. So one thing to note is he's doing the supraglottic maneuver so he coughs after each effortful swallow to clear any material that might be in his larynx. So that's why you hear him cough. And then I asked him his fatigue at the end of the set, and he says it was 6 out of 10. So at that point we took a break, and then we went on to the Mendelssohn exercise. But,
5, 6, 7, 8, 9. One last one after this. You're almost done. Good. And 10.
All right. Okay. The IOP, I've been talking about this for so long. Okay, this is what the IOP looks like, the Iowa Oral Performance Instrument. It's a calibrated device that we can use to objectively measure and increase tongue strength. So the patient places the bulb on the anterior or the posterior tongue as seen by the red arrows on the screen and presses the bulb against the roof of their mouth. So patient X was using the IOP to improve tongue strength, and I won't go into depth with his course of treatment with the IOP. You can actually find their research. It's pretty easily accessible how to use how they implemented their research for the device. And there's some citations actually. Go ahead. I'm sorry, say that again. So those are the two areas of the tongue we're trying to increase strength at. So the anterior part of the tongue is involved in different things, and so is the posterior part of the tongue. The anterior part of the tongue helps move the bolus around, prepare the bolus, and the posterior part of the tongue is involved in pushing the bolus back into the pharynx. So you want to, with this patient, we're trying to increase both parts. So you would place it in the front to increase that part of the strength, and then in the back later for that part. Any other questions? Okie dokie. So this is a chart showing patient X's weekly exercise regimen, including home and clinic practice. So each time he does pharyngeal exercises, he's exercising to a point of fatigue. So pharyngeal exercises, I mean the effortful swallow and the Mendelssohn. Every time that he did those exercises, he maxed out. He went to a 6 or a 7 on the fatigue scale. And because of that, we decided that he would alternate the days he does the pharyngeal exercises with days of rest. And he did the IOP program on the days that he was taking the rest. So you'll see on Mondays he's doing the IOP program, the tongue pressure against resistance. And then on Tuesdays he would come see me in the clinic and he would do the effortful swallow and the Mendelssohn with the SCMG. And then Wednesday again he would take a break from the effortful swallow and the Mendelssohn, do the IOP. Then Thursday he would do the effortful swallow and the Mendelssohn at home using his fatigue scale. Then he'd do the IOP on Friday, and then on Saturday he'd do his effortful swallow and Mendelssohn exercise again, and then Sunday he would take a break. And that was his schedule, but not every patient's schedule looks like this. Yeah, so we loaned it out to him. Yeah, we have a few in the office and we loan them out to patients as they need them. Yeah. I'm not sure how much it costs, so I don't know how expensive it is for a patient to buy one. But I think other clinics kind of do it the same way where they'll loan it out. So now that we know kind of what happens to muscles with structured training, let's talk about the effects of detraining. Patients participate in a therapy program for some weeks, some months, until they accomplish their objective. We've had patients that have come in for 4 to 6 weeks, and then some patients who have also stayed 12, 18 weeks, more than that. And as long as they're showing progress and they're making gains and it's benefiting them, we'll continue to treat them. So once they accomplish their objective, when the program ends, our patients often stop doing the therapy exercises at home, and research demonstrates that functional loss in muscle strength actually occurs a lot more quickly than gain. So we said that gain can occur in about 5 to 6 weeks if someone's really doing the program with sufficient intensity, repetitions, like increasing the intensity with systematically. And so the research does say that the loss of muscle strength occurs much faster than that. So when you stop training, skeletal muscle mass can decrease and the capacity to generate force can be significantly decreased. Has anyone kind of done an exercise program and then tried to do it a few weeks after they've stopped training and then you just really can't get back into it? It's kind of the same idea. Yeah. Okay, so I want to brag about this patient because he just did so well. He did therapy with me, I want to say for about 10 to 12 weeks. Around about week 7, he'd started gaining weight. He was able to take a lot more in. He started gaining weight. He was eating solid foods like burritos, popcorn, chili cheese fries, which were all his goals. When we began treatment, he was getting all of his nutrition through his G-tube, 6 cans a day, which is pretty typical. And it was taking him 40 seconds or longer to chew like a half piece of a Lorna Doone cookie. And then towards the end, he was only using the G-tube for 2 to 3 cans, and then he totally stopped using it. And he could eat a meal by the end in about 20-ish to 30 minutes, which is a pretty big deal for him. He was getting all of his hydration by mouth, and he was using the supraglottic maneuver for thin liquids. He didn't have any pulmonary issues during the time that I was seeing him. He reported that eating and drinking was pleasurable again. We were planning to do a modified barium swallow study at about 15 weeks after therapy, but he actually stopped coming. And dropped off his IOP because he didn't need it anymore. And that's, I don't know if there's no better sign than that. Yeah, he didn't need to. It was a long commute for him, so I don't blame him. And I think these are my references. Any questions? Yeah.
Could you go back just one slide? So,
Yeah.
Oh, right. When you're doing the supraglottic swallow, since it requires that cough after,
Mm-hmm.
so is that what he's going to need to do?
Forever.
Yeah. And what are the effects
Okay.
of coughing so frequently?
Those are good questions. He went through a lot of treatment for his cancer, and this is considered pretty functional for him. Even if he has to do the supraglottic maneuver, he can actually do the maneuver with several chugs of water and cough at the end too. So he doesn't have to do it for every sip. So that's a little bit better. And he's not doing like a very strong cough. It's more of like between a throat clear and like a cough. You could hear it on the screen. So I don't think that that's super irritating to the larynx, but he is being followed by head and neck, and they do scope patients. So if there's something they're worried about, they'll let the patient know. Mm-hmm. Yeah, good questions. Anyone else? No? Yeah.
I'm sorry if I don't remember the timeline. Did he start swallow therapy right after treatment? I noticed it was a year and a half. And
Yeah,
there was a delay.
I think
Why?
they found out that he had cancer 2015, 2016, and then he had some surgery, and then I think summer of 2017 he finished chemo radiation, and then I started seeing him 2018, early fall, like August probably.
So why?
Why the break?
Yeah.
That's a good question. I think at that point we were just sort of like ramping up our speech and swallow preservation program, which is something we're now doing at UCLA, where any patient who's getting radiation and chemo, but mostly radiation, will come see us for maximizing their swallow function, to preserve those for speech and swallowing, preserve those functions. So he wasn't part of that program. It could also be that because he lives quite far, he was probably getting some of his treatment elsewhere. And I think he may have seen a speech pathologist outside of UCLA. So he may have come here towards maybe just for the chemo radiation part. I'm just hypothesizing. And sometimes patients, even if the physician puts in the referral for swallow dysphagia therapy, they may not come, and it's kind of understandable. They're going through a lot, and having another appointment, having to think about more things is quite a lot for patients. So sometimes when they're ready for it is when they'll come. So it's a lot of different factors. I don't quite remember with this patient what happened. Yeah. Anyone else? Yeah.
How frequently do you see success stories versus? Is it the same as another areas of therapy?
It's really hard to say how frequently. I don't know that I can answer that well. We define success differently also for each patient. A patient might have had a massive surgery and lots of chemo radiation, or be extremely deconditioned after a medical event that happened, or have a traumatic neurological injury, and they might walk into the clinic saying, I want to be able to eat a steak for Thanksgiving or something, and that, if that's how they define success, we will do our best, but we may or may not be able to get them there. But I would say that it's success for some patients. It's successful for them to even be able to take teaspoons of water with an adaptation or something, and be able to do that successfully. There's some patients that's a big deal for them to be able to just do that much. So it sort of just depends on what the patient's goals are when we talk about success. Certainly, if we're trying to treat a patient earlier on, let's say if they just had their neurological injury and, like a brainstem stroke or something early on, and they're still within the first 6 months, we expect a lot more progress during that time. So it just sort of depends on what's going on with them medically. A lot of our patients are pretty sick, and we'll see them for 4 or 5 weeks of therapy. This has happened to me quite often, where I'll, see someone for a bit, and then they get readmitted, or they move somewhere where they can get care more easily. They have family, and then they can't come see us. Like, a lot of things change, so it's just sort of the nature of life. Okay, well, this is all I have. I'll be here for a few minutes. If you have some questions, I can answer them. Thank you. And Dr. Beal does have all of this, so he can probably send it to you guys.
Stop.